I'm very excited to talk to you today about two studies that we've conducted over the past few years. The first, as the title suggests, is about adult psychiatric outcomes for young people who have attended child and adolescent mental health services or CAMS. This work is in press at the moment in psychological medicine, so should be out within the next couple of weeks. The second study thinks a little beyond the psychiatric outcomes. So it looks at children who report persistent mental health problems throughout their childhood and asks what are their sort of early adult or emergent adulthood outcomes like, for example, their educational outcomes, their social isolation, physical health, as well as mental health and well-being. I have no conflicts of interest to disclose. So just a little bit of background. I think it's fair to say that children attending child and adolescent psychiatry service are a vulnerable group. Oh, sorry. And that this vulnerability doesn't disappear as soon as they stop attending. Child and adolescent psychiatrists often wonder what happens to their patients after they leave their services. And then from a parent's perspective of a child attending CAMS, will often wonder, well, look, what does the future hold for my child? From a psychiatry perspective, this is normally about who goes on to use adult psychiatric services in the long term, or who no longer needs psychiatric service input at all. But this could also be about other things. This could be about the patient's future life prospects. Did they manage to leave home and gain independence? Did they go to college or get the job or career path they want? They fall in love and start a family. Unsurprisingly, this is very hard to investigate because, number one, it requires making predictions about the future. And also, at the moment, there's very little data on any of these long-term outcomes. And part of the reason for that, or why that might be the case, is well, most studies to date are small because they are expensive to run and set up. Participants have to be followed up for very long periods of time. Some people drop out, and in fact, more often than not, it's the most vulnerable who end up dropping out, or follow-ups are in fact too short. One question that I often think about is, well, look, how representative are those who are even able to take part in a study of, say, a wider CAMS cohort? So for the first study, I'm going to talk about adult psychiatric outcomes of those who've attended CAMS. And in the second study, I'm going to look at some of the other outcomes. So what happens to young people who've been to CAMS at the moment, or to young people who've been to CAMS? At the moment, the best guesses come from consortiums like the Milestones, which is designed to look at sort of transition between child and adult mental health services, or AMS, as it's known. As part of the Milestones Consortium project, they asked child and adolescent psychiatrists in each of the EU member states to complete a survey. And what they found was that 43% of child and adolescent psychiatrists believe that 25 to 49% of young people attending CAMS will need to go on to adult services. An additional 32% believe that this number actually ranges between 0 and 24% would need to use AMS. So all in all, about 75% of psychiatrists believe that less than 50% of their CAMS patients would need to use adult services. When asked to consider what proportion of those under the age of 30 in adult services have been to CAMS, estimates range actually very widely from 10% to 70%, but the most commonly selected was between 20 and 30%, which was reported by 33% of psychiatrists. So these are more expert best guesses about, what proportion of CAMS patients need further psychiatric input in adulthood. It's not really the same thing as having data on those who have been to CAMS. The Milestones Project also examined what happens to children leaving CAMS and predictors of the care pathway. So they followed a group of about 760 young people at the end of their time in CAMS for 2 years. from sites all across Europe. And they found that there were 4 pathways that users took when they reached their upper age limit in CAMS. So 27% remained in CAMS for some duration of follow-up, but 3/4 has left by the end of CAMS. So these are some people who don't transition immediately and are kept on by CAMS services. 20% transition directly to adult mental health services. 40% end their psychiatric care, and an additional 13% initially end their psychiatric care, but actually end up going back to mental health services. So this is very useful knowledge about the transition between CAMS and AMS, but it's limited to a 2-year follow-up window. And as a result, it doesn't allow, you can't characterize the proportion of AMS users for whom were former CAMS users, because it takes a CAMS specific perspective. How might we look at long-term outcomes for young people? So some clever people in Nordic countries had the foresight to set up electronic registries, and these provide data on the entire population. And on the right-hand side here is an example of the coverage and timeline in Finland. And as you can see, in some situations, they have data dating all the way back to the 1950s. And approved researchers can access pseudonymized versions of these registries. The registries of interest for our purposes have little asterisks next to them. And these include an inpatient registry dating back to the 1969, the medical birth registry, which was started in 1987, and the specialist outpatient registry, which includes CAMS outpatient services, which started in 1998. So every time a person comes to hospital or for a psychiatric appointment, their data is entered into this system. An example of some of this information in these registries includes the diagnosis on admission, the specialty seeing the patient, admin and discharge dates as well if it's an inpatient stay, or admin date in the case of just an outpatient appointment. So because of the medical birth registry, we now, some of those born in the 80s and 90s are now coming of age to examine longitudinal outcomes for those who have had an inpatient or outpatient CAMS service use, which I'm happy to say we were able to look at. But what outcomes are of interest? So outcomes can be appealing to both clinicians, while others might be appealing to service managers or policymakers. And we thought some mutually interesting outcomes might be inpatient admissions in adulthood, the number of bed days in adulthood, or the duration of the inpatient stay, number of outpatient appointments in adulthood, as well as the different types of adult diagnoses that the patients receive. So our study one aims were to examine former CAMS users' contributions to the proportion of all adult psychiatric outcome appointments, the proportion of all adult psychiatric inpatient appointments, proportion of all adult psychiatric inpatient bed days, and the proportion of adult mental disorders diagnosed by age 29. We also examined the cumulative risk of any mental disorder, and here I'm also going to report the most common mental disorders reported in adulthood by former CAMS patients. So, as mentioned, to do this, we use registry data for all individuals born in Finland, and our years of inclusion were from 1987 to 1982. To the final date of the investigation ended in December 31st, 2016, which means that our adult or former CAMS patients at the end of the observations range between 25 and 30. We then use registry linkage to identify the type of service, the diagnosis, and those who died or emigrated were censored at the study at the point of death or emigration. Broadly, the timeline can be observed as from birth as far as 18 is sort of our exposure window, for CAMS usage, and the outcome windows then range from 18 to 29, with outcomes including adults, inpatient admission, duration of bed days, and inpatient treatment, outpatient appointments, and diagnosis. So there were just over 373,000 individuals in the sample, of whom 49% were female, and just under 12%, so about 44,000 children attended CAMS at some point in their lives. And there were more females in the CAMS group than there were males. So the first results is on, we look at the outpatient appointments. So by age 29, there were 54,000 individuals had attended at least one adult psychiatric outpatient appointment, and the total number of appointments attended in the sample was about 1.3 million. So of all of the 1.3 million adult outpatient appointments that were booked and seen in the sample, more than half of them were from former CAMS patients. In those who have at least one appointment, CAMS patients attended more than twice as many appointments, with a median of 10 appointments in users with a history of CAMS and 5 appointments in users without a history of CAMS use. What about adult inpatient admissions? So we had 14,000 individuals requiring a psychiatric inpatient stay in adulthood by age 29, and the number of individual appointments was 45,000. And of this 45,000 individual inpatient admissions in adulthood, again, over half were from former CAMS users. And when we looked at the number of admissions on average, so within those who have at least one admission, former CAMS users have twice as many. Okay, so the number of admissions is one thing, but what about inpatient bed days? How long are they spending in care? So the number of individuals in the cohort in hospital, sorry, the number of days an individual in the cohort was in hospital for psychiatric admission in adulthood was about 2.2 million. What proportion of these bed days come from former CAMS patients? A little over half were filled by former CAMS users. And CAMS users with at least one admission have a higher number of total bed days and a higher number of bed days per inpatient care stay. So they're using more bed days total and on average per visit. Okay, well, what if this is just about the period when people transition from childhood services to adult services? So all this is about, people before their 20s. To illustrate that this isn't the case, we have a look at the age of first adult inpatient admission in CAMS users and non-CAMS users. So this figure, we have the cumulative percentage of first adult inpatient admission over time, and it's then been stratified by whether you attended CAMS in childhood or not, with the blue proportion representing non-CAMS users and the red proportion representing CAMS users. And as you can see, this isn't just about early first attendance, as first attendance in both CAMS and non-CAMS users occur right up until the age of 13. So the previous results aren't just about this handover period, it appears. Moreover, this image is just about the first admission per person, but this is an undersell because we know those with a history of CAMS have multiple admissions. What were the most common mental disorders former CAMS patients had in adulthood? So 52% of former CAMS users had a mental disorder reported in adulthood by age 29. And the most common disorders were depressive episodes, followed by anxiety disorders, personality disorders, and substance use disorders. Down in the bottom of the slide here, I've included meta-analytical evidence of the percentage of each of these diagnoses that occur before age 18. So that's what this column represents. Is to give you an idea about whether the disorders are the same as in childhood or differ from the childhood presentation. So certain conditions like anxiety disorders may have already been present in childhood, but for I'd say most, if not a lot of the other disorders, only a small proportion of these cases will have had this diagnosis in CAMS. Finally, what proportion of all adults with the most severe or service use heavy mental disorders are former CAMS patients? Here are the results for schizophrenia-spectrum disorders, bipolar disorder, personality disorder, and recurrent depression. These disorders broadly take up the largest proportion of adults, mostly inpatient service use. So CAMS users are accounting for 45 to 55% of cases of severe mental disorder in adulthood, including 45% of schizophrenia spectrum cases, 48% of bipolar cases, 54% of personality disorder cases, and 49% of recurrent depression. And here again, I've included the meta-analytical evidence for each of the disorders, just to give you an idea of what percentage may have had the diagnosis before age 18. So I'm aware that's a lot of information, that's only study one. So let's just recap very briefly. So CAMS users are accounting for over half of all adult psychiatric service use by age 29, including adult outpatient appointments, adult inpatient admissions, and adult inpatient bed days. The most common mental disorders in former CAMS patients were depressive disorders, anxiety disorders, personality disorders, and substance use disorders. Former CAMS users are accounting for almost half of all severe mental disorder presentations in adulthood. So this is probably, if you were to take away anything from this presentation, this is the slide I'd like you to pay most attention to, or at least it's the one I think is the most important. And I tried to contextualize the findings. And here is the scenario we are facing. So we have this total population of which about 12% are attending CAMS at some point in time. And roughly half of this CAMS group go on to use adult services, so about 6% of the total population. And this 6% or so are accounting for the majority of adult psychiatric service use in the under 30s. And they have, in fact, already been identified as help-seeking years earlier in prior service. Yet, according to the Commons Library in 23 and 24, CAMS in the UK received only 8% of the mental health budget, or 0.6% of the total NHS budget. And the data I just showed you suggests that this group might be capturing as much as half of those who go on to develop severe mental illness in adulthood, or over half of all adult service use in the under 30s. I have to say, this sadly to me looks very much like a tragic missed opportunity. Really, I hope this highlights the importance of examining this vulnerable group and the need for investment in CAMS. So some thoughts for the future. We need more studies examining the characteristics of CAMS users who go on to these adult services. I have some additional slides which I'm happy to discuss on some stratification if people are interested. Nationwide, this is a nationwide cohort with an adult population, outcomes ranging from age 25 to 30. What about after 30? Well, we know from meta-analytical data that 2/3 of those who go on to develop a mental disorder do so by age 25, and 3/4 do so by age 34. So we suspect we're capturing the majority of first cases. So it'll be actually quite exciting to see what happens after 30 years. We have good coverage of psychiatric healthcare usage through registries. The question might come to you as well, look, this is Finland. Are these results generalizable outside of Finland? We have colleagues at the moment looking at Welsh registry data. And what they're finding is that a similar proportion of CAMHS users in the Welsh population, and that former CAMHS users are accounting for a very similar proportion of future psychosis cases, 44% instead of 45%. So this doesn't appear to be specific to Finland. So the conclusions from study one are CAMHS users are accounting for half of all adult psychiatric service use in the under 30s, including 50% of severe mental illness in adulthood. The most common adult mental disorders in former CAMHS patients were depressive disorders, anxiety disorders, personality disorders, and substance use disorders. I kind of hope this study serves as a call to arms for more research within CAMHS population. If you want to understand the mental health trajectories of those who develop lifelong conditions, or in fact, in a perfect world, prevent the development of these conditions in the first place, CAMHS seems like a fantastic starting point, but that means you need funding and you need research. Moreover, the outcomes that were important for study one are only a proportion of a young person's life, and in many scenarios, it may not be the most important aspect of their life. There are many other important outcomes like job prospects and independence, and these are equally as important to understand in this for this vulnerable group and how they're doing in adulthood. And that sort of leads me on to the second study, which is about emerging adult outcomes for those with persistent psychopathology as opposed to CAMHS use in childhood. This work was completed with Professor Mary Cannon, and you will notice a dramatic upgrade in the slide quality, and that's because the next group of slides were designed by the excellent Dr. Niamh Dooley, who is now doing the fellowship in RTSI in King's College. Niamh was first author on the work I'm going to present, so I really want to give her a shout out. And as I mentioned, it's sort of these two groups are slightly different, so these aren't exactly CAMHS users, but they do represent a proportion of the population for whom are having significant mental health problems. So study two looks at emerging adult outcomes for children who have persistent mental health problems from childhood into adolescence. And the data from the study comes from over 5,000 children from cohort 98 of the Growing Up in Ireland study. And we used 4 waves of data for this investigation. So 2 for the exposure and then 2 for the outcome. But how do we define persistent mental health problems? This comes from an additional paper that we had worked on back in 2022, where we looked at the trajectories of mental health problems across childhood and adolescence for all waves of the Growing Up in Ireland study.
Tylko, że mówić głośno, bo i tak go nie rozumiem.
Questionnaire. And we use latent profile transition analysis to model the data. And broadly, what we observed was that there were 4 main profiles. The first is no psychopathology, and this accounts for 65% of children at any wave of the study. The next is internalizing problems, so this is problems with depression and anxiety, which accounts for between 7 and 10% of children at any wave of the study. The third is externalizing problems, so this is problems with conduct and attention, which accounts for about 20% of children at any wave of the study. And the fourth is a combination of these 2 issues present in the same individual. And these account for about 5% of children studying, and we've labeled them high psychopathology. You can also see from this image is there's some shifting between the waves, which there's plenty to mention. I'm happy to talk about afterwards if you want to discuss. But for the purpose of this investigation, we just concentrated on those who had the same class at both ways. What outcomes did we look at? This was in part based on the availability, and the outcomes collected were at age 17 and 20. So we were able to gather outcomes on a number of domains, including poor mental health, poor physical health, heavy substance use, social isolation, poor subjective well-being, poor education and economic outcomes. And each of these domains were derived from several questions within the GUI dataset. And I'll just give you a little bit more information on the next slide. Might be a little bit difficult to read, but this gives a breakdown of what makes up each of the domains for age 17 and 20 data. For example, our substance use outcome includes daily smoking or alcohol use disorder based on the audit. Social isolation were reported having no one or very few people they could call a close friend, or no perceived social support at age 17 or 20. On the right here is just a characterization of what these children look like at age 13. So for each of the four groups, a high percentage of those with persistent externalizing problems or persistent high psychopathology were male. A greater proportion of those with persistent high psychopathology were from the bottom family income quartile, or had reported an autistic spectrum diagnosis, or who had already accessed some mental health services. Those with persistent internalizing problems were more likely to have reported fewer friends or having been bullied in the past 3 months. So if we combine any of the forms of the persistent psychopathology, these individuals have roughly a 1.5 to 2-fold increased odds of each of the young adult outcomes relative to those who never had psychopathology. However, this kind of finding probably isn't too surprising and might mask some interesting profile-specific associations. So this, I think, is a more interesting way to discuss the information. So on this slide is the percentage of each of the group who meet the criteria for the poor outcomes in each of the domains. And what we can see is that groups have different level of risk. So over 30% of those with high psychopathology and 25% of those with externalizing issues have heavy substance use, and this is very much in line with the literature. Around 30% of those with the 3 psychopathology groups have issues with social isolation. Over a third of those with persistent high psychopathology and persistent externalizing problems have poor mental health issues at age 17. Persistent internalizing problems have poor mental health outcomes at age 17 or 20. Poor physical health is predominantly related to internalizing issues in childhood, with almost 40% having difficulties at 17 or 20. GP and ED service use was only ever so slightly elevated, and over half of all 3 of our persistent psychopathology groups have difficulty with educational attainment or economic circumstances. And 45 to 50% of the 3 psychopathology groups also had poor subjective well-being at age 17 to 20. So these are the corresponding adjusted odds ratios for each of this investigation, and largely replicates the information I showed you on the previous slide. There's mostly overlap in the confidence intervals between the 3 groups, with some noted exceptions that were previously highlighted. And the increased odds are broadly ranged from 2-fold to a 3-fold increased risk. So we demonstrate that children who have persistent mental health problems in early life do poor on a range of psychosocial outcomes in emerging adulthood. Some poor outcomes are group specific, some are not. Neve has titled this slide the Who Cares slide, and she came up with a few ways of thinking about this. So first, we could take the pessimistic view and say, well, look, this is unsurprising and worrisome for children with psychopathology. Alternatively, we could leverage this information to provide incentives for the government to invest in childhood mental health services. It also suggests that we need to indicate prevention across multiple areas. For example, when we think about the interventions offered in CAMS, we frequently think about talk therapies, medication, inpatient hospitalization. And I hope you agree that after the data I've shown you today, that we need to think a little bit more broadly for these children. CAMS or some adjunct service needs to consider the long-term outcomes of children, including psychiatric outcomes from our first study, but also educational, employment support, social support, and physical care support. And the types of support required may depend on the profile of the person. And for example, say targeted substance use for those with externalizing issues. So I'm going to conclude in a second, but I just wanted to finish up by saying that I think we're now at the stage where the data is beginning to back up what we long suspected. Children attending CAMS, as well as those with persistent childhood psychopathology, can and frequently do experience difficulties in adulthood. And these difficulties definitely can include a variety of mental health problems and adult psychiatric service use, but also include social and economic problems, all of which have a real impact on these people's lives. CAMS is a reactive service, and that is to say that when a child attends CAMS, they go there because they're experiencing difficulties, and it's these difficulties that are being treated by the service. And I think it's really time to start thinking about sort of life course investment in services, such that there is scope not to just think about a child's current situation, but the future risk in adulthood and how to provide supports as needed. However, again, this requires serious investment in services and more research. I also really, this is really important, I would like to caveat all this by saying the CAMS in the UK and Ireland are an overworked and under-resourced service. And the message from this talk today is definitely not that CAMS needs to do all this extra things. They need resourcing and funding to do the best for their patients. It will be easy to argue that some of the long-term work is perhaps beyond the remit. So I'm suggesting an additional role that is useful for thinking long-term about patients, sort of a wraparound approach, and how we can sort of maximize their long-term success and minimize their risk, sometimes through intervention. Speaking of which, there is a whole area of preventative science in psychiatry that is underexplored. For example, at the moment, we don't know if the treatments or interventions provided in CAMS have a preventative effect on adult outcomes, psychiatric or psychosocial. The treatments provided in CAMS, like all medical specialties, are designed to treat conditions, specific conditions, and not prevent other conditions. So there's a whole field of work that needs to find out if any of the treatments currently being provided have downstream effects. And that's very challenging work, so there's still quite a lot to do. So with that, I would say thank you very much to the wonderful people listed here who contributed to the second study, particularly Dr. Neil Dooley and Professor Mary Cannon. And a huge thanks to Professor Ian Kelleher and his research team for all the work in the finished data. And thank you very much for listening. I'm very happy to take any questions.